Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is 2026 Medicare Physician Fee Schedule Final Rule Part 2. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the Q&A pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any additional comments. Any questions posed during the webinar will be responded to via email after the webinar. You can customize your viewing experience by sizing, moving, or minimizing all of the panes within the webinar.net platform. We've posted a PDF copy of the presentation slides for your reference in the Resources pane. Also, you'll receive an email later today with a copy of the slides and the recording of the webinar. With that, I would like to introduce our presenters, Marty Ross and Valerie Rock.
Thank you, Jennifer, and good morning, everyone. Thank you for joining us for the last webinar of 2025. And what a year it has been. But we are going to go out with a bang, addressing the second half of the Medicare Physician Fee Schedule. If you joined us last week, we covered in part one the conversion factor, the new efficiency adjustment, the practice expense methodology, MIPS, ASM, and MSSP, and all the acronyms. So today I am joined by my colleague, Valerie Rock, who leads PYA's Revenue Integrity Team. She is a true aficionado when it comes to the Medicare Physician Fee Schedule. She sees all the details. So she's going to cover today the telehealth changes, the global payment reforms, and skin substitutes. And I'm going to bring us home with care management and wellness and prevention. So Valerie, over to you.
Thank you, Marty. So we're going to kick it off and talk about a bit about the telehealth services and where we are with that. And of course, it's been a subject of a lot on the news regarding healthcare and where we're at, especially with Congress, because telehealth and Congress are very much linked, right? So we have to wait for them to make the changes with telehealth with the 1834M before we actually are going to see changes to telehealth, but we will eventually see those changes as they can determine how to pay for them. But we do have some things that we still have in place and we can still move forward with, including the telebehavioral health services that are covered, and especially through 1/31/2026. The expectation is that you would have a face-to-face visit with the patient within 6 months, and then every 12 months with the telebehavioral health visits through 1/31/2026. That has been extended to not require that, but until we get that fully fledged and fully in place, we will still see that be required. I know that there's a lot of people that are pushing against this to say what we need. We've pushed everything forward during COVID and we're, in place now. We're all doing this all remotely. So how are we going to move this forward into a face-to-face visit? Many people don't even have brick and mortar places to do this. So there's a lot of push and pull around these guidelines, but we will continue to see this move forward. With the way that telehealth is implemented and the way the codes are determined has in the past few years been through a 5-step process. And CMS decided that it wanted to make it a little bit more streamlined by removing the 4th and 5th step to really focus on, is the service applicable to telehealth effectively? So is the service a Medicare Physician Fee Schedule paid service? Is the service meeting 1834M, which is the telehealth provision, which means, is this with a physician or an APP and an in-person encounter, and then otherwise substituted with this telehealth visit? And are all of the elements relevant to the code applicable to something that could be done remotely? And so they're working through this process instead of adding additional components that work into the safety component, et cetera. In addition, during COVID, there was a provisional status to say, okay, well, maybe during COVID, this is okay, but in the future, maybe we want to take this away. And what they've determined is we're just going to call all of the codes that are on the telehealth list as permanent, and we have the discretion to remove these if we want to. So they're trying to streamline the process and give you the ability to more quickly determine if you have services that you want to apply to be covered under the telehealth provision. You can submit those codes between now and February 10th of 2026 for any codes that you want to be considered for the following year. So the codes that they're looking at currently and that they worked through the proposed rule and received feedback include these added codes to the left of the 90849 multiple family group psychotherapy, G0473 group behavioral counseling, G0545 for the infectious disease inherent complexity code, and these two 9,000 codes for the auditory osseo integrated sound processor programming. These all met those three criteria, whereas the codes that they did not add did not. And so that you can see how these kind of play into the three criteria and they miss the mark in certain instances. So in the dialysis codes, the 90935 through 90947, they said, well, you can't do the entirety of this visit remotely. The INR monitoring is really done mostly by a clinical staff as opposed to a physician or APP. And so they said that that did not qualify for a telehealth service. And then the 98,000 codes that were the additional codes that the AMA added for E&M services provided by telehealth are not yet covered by CMS. And therefore, these are not applicable to a Medicare physician fee schedule payment. So one of the codes that they turned on was the SDOH code, though. They did not delete the code and they did not remove it from this list. And Marty will talk about this later under the care management provision. They also did decide to finalize the removal of the frequency limits for the subsequent inpatient visits, the subsequent nursing facility visits, and the critical care consults. So we no longer have those limitations that were set prior to the telehealth provisions and then further allowed under the telehealth provisions. They saw that there's not a whole lot of data under these codes provided in a telehealth setting. So they're not so worried about any safety considerations or compliance concerns here, and thereby allowing the physician to make the discretion if that would be appropriate, which is really a theme, Marty, I think that we're hearing throughout the final rule, even in the proposed rule, et cetera, and all the rules, that they're putting a lot more onus on the physician to make some determinations on which setting should be and all of that, and even taking down the expectation from payment and kind of aligning the payment all the way from the physician practice setting to the hospital setting. So then it's not a question of payment, it is what is appropriate for the patient. And so because of that, the medical necessity expectations, the setting expectations can then later be scrutinized as for coverage, but on a case-by-case basis, because it'll be specific to the physician's discretion and the beneficiary's need. So we're going to see maybe some lowering of the bar, but then a higher expectation to defend yourself in the event you decide to have, do additional services or have the patient in a higher acuity setting. In addition to this, we're seeing an expansion of the virtual direct supervision. There's going to be a permanent allowance of the real-time audio video supervision of the incident to services. What they're doing is they're taking this definition of immediately available and adding not only being in the suite, but also through audio-visual real-time communication. Audio only is excluded as a note. They are excluding the global surgery indicators of 10 and 90 from this permission. So if you have any actual surgical procedures, then that would not be included in here. What it does include is incident to services. I'll note that this provision of 41026 is only speaking to those status or category 5 and the 99211 services in its provision. So that's specifically what they're talking about, and those that they included in the 2025 fee schedule. Diagnostic tests, pulmonary rehab, cardiac rehab, intensive cardiac rehab, and certain outpatient hospital services. So if any of your services qualify under any of these provisions, then you can continue to provide these under virtual direct supervision, ensuring that the physician is available by that audiovisual real-time communication. The teaching physician virtual supervision, they were originally looking to remove this extension of allowing the physicians to provide these audiovisual supervision, even all the way into these three-way telehealth visits. But there was a lot of pushback on not, taking away this opportunity, saying that if we're providing these services effectively in a telehealth setting, then we need to be able to teach the residents how to provide a service in the telehealth setting. So we want to be able to, be able to tap into that and be there for the key provisions and all of that. So why don't we continue to do this? And they actually took a 180 and said, okay, we'll continue to allow this. So this was I guess an effective win for these provisions. So we'll continue to see this allowed. The FQHC and RHC segments had some shifts here. They are, as a reminder, permanently allowing the FQHCs and RHCs to provide mental health visits via telehealth. The 1-year extension to bill for the non-behavioral health visits under the G 2025 is being continued through December 31 of 2026. So you will be allowed to bill for those telehealth services for the non-behavioral health services under this G code. There was some back and forth on how they were going to pay for it. They decided to not go with this air rate model, to still continue on basically a weighted average of all the telehealth services under this G 2025 related to the fee schedule.
Valerie, don't get too excited though if you're an FQHC or an RHC, because again, if we don't see the waiver renewed at the end of January, then that requirement that the patient has to be physically present at a rural facility at the time the services are delivered will still apply. So
Right.
Yes, they can bill for it, but only if it meets those strict 1834M requirements, assuming the waiver is not, extended. Please let the waiver be extended. Please let them make it permanent. I mean, let's get to what we really want here, right?
Yeah, right.
So.
Yeah, which seems, I think at this point, the genie's out of the bottle, the cat's out of the bag, whatever you want to call it. We are in this mode of telehealth, and I think, there's still people being seen in person. It's not being overutilized per se, but we're still seeing the need for this, especially in the rural health setting. And even at home in the rural health setting, right? So we want to make sure that these provisions are allowed. I think the biggest question is, how are we going to pay for it? And I know you've spoken about this before, about how, it's being seen as needing to be paid for, as opposed to maybe how it really needs to be paid for, that it really is a replacement as opposed to an addition to the budget. And so if we can get to a point where we all agree on what this really is going to cost, then I think we can get it over the hump. Yeah. So then one of the aspects that was trying to be pushed forward was an extension to allow or to prevent people or physicians that were providing services out of their home from using their home address as a part of their enrollment application. But there was an FAQ that was submitted, recently, and there's a link here in this slide that basically says that you have the ability to suppress your home address in your, what's going to be seen at Pecos. And you can even do this all the way to a clinician's practice location, even if it's a brick and mortar location. So they said, we don't feel like we have to or need to remove this or stop this from moving forward. So make sure that your enrollment is updated if you're providing services, your physicians are providing services out of their home alone, right? So if they are, predominantly done in a physician practice setting, that's one thing. But if they're done out of the home, then that location needs to be included in the application process. So now we're going to move to the global payment reforms, and top of the line, there's nothing moving forward here. This is just communication about what they're thinking about and have been thinking about for the last 10 years effectively. And initially they wanted to remove all of the post-operative global portion of the visit, and so that you would just be billing E&M services. And that was pushed back 15 years ago. So they've been stepwise trying to figure out how to really adjust the payment to be more accurate, because they generally find that the E&M services that they're including in the valuation of the code are not actually being performed to the extent that they're applied. So they want to make sure that they're getting this corrected. So they've requested public input during the proposed rule phase. You can see these questions here, but generally they're trying to get a sense of how do we go about moving this needle and paying for these appropriately. As a reminder, the 54 modifier is being asked to be used as of 2025 whenever the physician decides to not provide the postoperative care and delegate that to someone else, even if there's no formal agreement between the providers. The assuming provider can use the G0559 in addition to an E&M code to address the additional, complexity of the service when provided in that scenario. But the concept generally is not accepted well. And because the volume of these providers actually utilizing this modifier, they still want to move forward with some differences and changes around the payment. And so there's 3 proposed approaches that they still continue to speak about in the final rule. And again, these are not finalized. Nothing's been finalized. They're still trying to figure out what they're going to do. But they're leaning in on this approach 2, and which goes into the data that they've been pulling since they've been pulling from the 9 states of providers billing the 99024. They have the data available to say how many visits are being provided for each of these services, so they can use some kind of weighted average there to figure out, okay, what is the value of the service, as opposed to taking the assumed values of the work RVU percentage or a time-based percentage and applying that, which they believe to be false in their data as a source. So if they could go to this approach 2, then they would, perhaps be paying for the services more appropriately. Again, not finalized. So the concept behind this is that currently for the 90-day global, they're paying about 80% of the service as part of that initial part of the service, as opposed to the postoperative service. And then for the 10-day global, they're paying about 90% of the initial part of the service, and then the 10% for the post-op. But they're finding, again, only about 28% of the 90-day global E&Ms are being provided in the post-op period, and 2% of the 10-day. So why do they want to continue to pay this at this value? That it makes it challenging, right? So if they went to this claims-based approach, and approach 2, as on the prior slide, then they would move the average share from 82% to 91%. So then the surgeon that's providing this initial part of the service would actually increase the value if they build the 54 modifier, as opposed to currently today, it would be about 80% of the value of the total, basically RVUs of that. So if we move towards this, it would be a higher payment for the person that is, doing the initial care. And if we move to this, as we already have this informal approach, then the post-operative provider can bill an E&M and bill the initial visit with the G code, and then everybody's happy. So there may be a way to move this forward that would have an upside to everyone. So it will be interesting to see how this moves forward and if it moves forward. So the last segment that I'm going to talk about is skin substitutes. And this has been a significant shift in how we're going to pay for these services. So to get everybody on the same page, historically, the focus of these types of services has really been around two specific services that are accounted for within the 15271 and 15278 that describe the wound size and anatomic location. But the way that the supply was paid for was based on the ASP plus 6% methodology for each of those specific supplies. But what CMS found was over the past 5 years, the cost has gone from $250 million to over $10 billion worth of spend related to these services, and only the patient count has only doubled. So whereas there was a 40-fold increase on the costs, the patient count has only doubled. So they can see that there's a misalignment with this, that the value has increased without any kind of mitigation or regulation, and they want to get this aligned and figured out. So they've included skin substitutes on the OIG work plan to start looking at this, but they're also deciding now to finalize a standardized payment. In the midst of this, there was an LCD that was released April 25th of 2024 that talks specifically about skin substitute grafts that are cellular and tissue-based products for the treatment of diabetic foot ulcers and venous leg ulcers, these being the two predominant services that are provided related to these skin substitutes. There was a delay in its implementation until January 1 of 2026. So we're right on the precipice of this being finalized or implemented. And the final rule mentioned this LCD and did not say it was going to be extended or anything like that. So it appears that everything is going to move forward. We're going to have this regulation on the payment side, and then we're going to have this regulation also on the coverage piece. So make sure you know specifically what's related to this LCD, and if your services are covered, if your supplies are covered, or if they're no longer covered because of the limitations included. In addition, there's limitations on the number of applications that can be provided, et cetera. So there's a lot going into this that is pulling back on what you will be permitted to do. So again, we're going to have a single rate across all of the services that are supplies that are related to specific criteria. And I'm going to show you that here in a minute on these specific services that are applicable here. The volume weighted average for the 361 HCTP supplies are the ones that the skin substitutes are the ones that they're focused on, and they're going to use that weighted average there, and that's how they got to the 127.14, which is slightly higher than about 125 that they had previously when looking across all of the categories of service. So they are expecting to save about $10 billion in order to apply this methodology. And so you'll want to keep an eye out on how this is going to impact your practice. There is a correction on this section from the final rule to this correction that is linked here. So if you are looking at the final rule, be sure to supplement that with this correction because there are some differences, especially that payment rate. So the three categories of service that are applicable to this payment method at the 127 per square centimeter are the pre-market approved or PMA skin substitutes, the 510K cleared or de novo pathway devices, and the 361 HCTP, the human cell tissue and cellular tissue based products. These three are the ones that are applicable to this. Now, when CMS originally put this out on the proposed rule and they had the list of services, there was feedback from the community that said, actually, some of these are labeled incorrectly. So they went back and said, well, the valuation of this, if we relabel this, is actually too far off of what we were looking to do. So we're going to value it based on the way we originally looked at it, and then prospectively have these appropriately assigned per category. So look at your categories of your products and make sure that you know where they line, but the payment is going to be the same across each of these. So you'll bill out the CPT code for the application, and then you'll bill out the supply code for the services, and the supply code will be paid the same across all three of these categories. What this does not apply to is the products that are considered biologics, and they've redefined biologics to only include these services that meet the Section 351 specific provision. The products that are not in sheet form will be paid as incident to supplies as priced by the max. So that's another addition to the aspect in this final rule. So again, the three categories that are sheepskin substitutes or covered sheepskin substitutes will no longer be paid under Section 1847A. They will now be paid under this new flat fee methodology. The ASP reporting for the skin substitute manufacturers is now voluntary for these specific ones. It's not voluntary for the one that falls outside of this. And then the CPT codes would be billed with the supply code and as an incident to supply in the non-facility setting. Because these supplies are always billed with the application, they're now also converting these supply codes to add-on codes and indicating them as a ZZZ indicator. So what we recommend going forward is to make sure that you know what FDA category your product aligns with. If you're utilizing several products or one product, make sure you know where that fits, because future rulemaking may actually split these different categories into different tiers and pay for them separately or differently. So you want to know where you fit in the process and watch the proposed rule next year as these may be changed additionally. Look at your supplier contracts and make sure that you know how this change impacts you. Are you paying for your supply up front, or are you paying for it on the back end of your, after you receive the supply? Will this impact your, ROI on your supplies? Determine if any changes need to be made, both from an education perspective to your staff or your billing staff or your coding staff, because all of this works through all of your processes. And so they'll need to know exactly how to handle these and how to have the charges flow through appropriately. And as was mentioned on our OPPS webinar as well, this is impacting all the way from OPPS, so the outpatient hospital setting, all the way to this outpatient clinic setting. So this will be a change all the way across the board. Anything to add to that, Marty?
Yeah, we talked about this with OBPS. It was just kind of stunning how expensive skin substitutes had become. And CMS, when it announced the 2026 premium and deductibles for traditional Medicare, noted that the rates would have been $11 higher a month had they not made these changes on skin substitutes. So it's just sort of stunning, but it also tells you that CMS just has this incredible power through rulemaking to really disrupt the industry. Because this is certainly going to be impactful for those providers that have been regularly billing for skin substitutes. So it's always something, right? We'll see what it is for 2027, right?
That's right. So I'll turn it over to you now, Marty.
Okay, let's talk care management and what CMS has done here. And we started this journey back in 2013 when CMS first provided reimbursement for transitional care management. And over now 12 years, they have expanded the services that are reimbursable, even though they are not delivered face-to-face. They're not telehealth services because they aren't replacing what would be a face-to-face service, but now are reimbursing for services furnished outside the four walls of the hospital or the clinic. And as they've developed up these services, they've also refined them based on industry feedback, as well as their analysis of claims data as they see the uptake and utilization of these codes by providers. So it's sort of always an odd discussion when you talk about care management, because CMS is doing its best to encourage providers to deliver these services and trying to clarify the rules and eliminate the ambiguities and the like. Whether they've accomplished that, we'll leave that for another day. But let's talk about what changed in 2026. Now, 2025, the big news, of course, was APCM, Advanced Primary Care Management Services. And this was CMS saying, we're going to provide reimbursement for a practitioner that assumes the responsibility for providing care management services, but does not necessarily provide 20 minutes of service every single month. So as an alternative to billing on the time-based codes, we're going to create this reimbursement for APCM for those providers that have the care management capabilities and have received consent from their beneficiaries to deliver these services on an ongoing basis. And CMS created 3 codes and divided them based on the severity of the patient's condition. So the lowest core code, of course, is for those beneficiaries that have one or no chronic conditions. The middle code for those with 2 or more chronic conditions. And then the third code for those effectively dual eligibles that qualify as that meet the definition of a qualified Medicare beneficiary. And of course, the reimbursement varies significantly through these 3 codes. GO557, which is the 2 or more chronic conditions, the reimbursement there is slightly lower than the reimbursement you would receive for 99490, which is the CCM base code. So yes, we're not tracking time, but obviously having the ability to track time, deliver that 20 minutes is going to enhance your reimbursement. But this has been creating an alternative, working with providers who deliver care management services. APCM has really provided a strong base for them to continue their programs, because for just an assorted number of reasons, you don't hit the 20 minutes. If the beneficiary doesn't answer, that there's other demands on staff time that require that they pay attention to certain beneficiaries, but still are, managing these beneficiaries in indirect ways. So it really has stabilized, or at least provided a vehicle to stabilize these care management programs. So the big development for 2026 is the new add-on codes. That CMS is now going to pay additional funds to a provider who furnishes APCM or has the infrastructure for APCM when they enhance those services by making available behavioral health integration services. And again, 3 codes, but these are not tied to the patient condition. Instead, it is tied to the vehicle that the provider utilizes to deliver behavioral health integration. So we have level 1 code, which is the initial psychiatric collaborative care model. The second is subsequent psychiatric collaborative care model. So we start it. If we start CCOCM, we bill under GPCM1. If we continue providing those services month after month, we bill that under GPCM2. And then alternative to the COCM model, which involves a psychiatrist, is the care management for behavioral health conditions, or the general BHI as we refer to it. And that gives your 3rd code if you're providing services that way. Again, none of these codes have minimum time requirements. And if you build COCM or BHI currently, you're doing that when you meet certain time requirements specified by the codes. The add-on code does not require that. Appreciate that the BHI services can be delivered directly by the billing practitioner or by clinical staff under the supervision of the billing practitioner. We'll talk about that as we go into greater detail on what the codes entail. And emphasize and underline 3 times, CMS makes clear that you're going to need separate consent for when you're delivering APCM. If you are providing the enhancement of behavioral health services, you need to have consent to both. So I've described the services in the consent form and ensure that the patient is acknowledging they're receiving both. So let's talk about how these add-on codes work. And you do that in reference to the CPT codes for when there was time required for delivering these services. So the correlation for GPCM1 is 99492 and 99494. And this is the psychiatric COCM, meaning that is a 4-person care team when you're delivering COCM. It's the treating provider, it's the BH care manager, that clinical staff member, it's the patient, and then critically important here, it's the psychiatric consultant. And the idea behind COCM is that you have a BH care manager within the practice who is managing a panel of patients, and then on a weekly basis is touching base with the psychiatric consultant to review any particular cases, to identify need for adjustments for medications, and similar type of engagement between that behavioral health care manager and that psychiatric consultant. Now, the psychiatrist is not separately billing for the services they provide. Instead, it's the reimbursement that's received by the treating provider, who then allocates a portion of that reimbursement over to the psychiatrist for the time spent. And that really has been a challenge with COCM, is developing those working relationships between primary care and the psychiatrist. But it's very clear that this is CMS preferred method of delivery of these behavioral health integration codes, but acknowledging, of course, that these relationships and the management of these conditions certainly can be challenging. But by creating the add-on code, when you're doing APCM and having the BHI add-on code, CMS hopes that this is greater flexibility that can further forward the model. Again, for the first month that you're providing these services, sort of getting the process stood up for a particular individual patient, you're going to build the GPCM1. Then for subsequent months where you're delivering these services as part of as an add-on to APCM, you're going to build the GPCM2. Again, the alternative to not involve a psychiatrist is GPCM3. The equivalent CPT code is 99484, again, general BHI. And this is really when you have that care manager playing that behavioral health care manager playing that critical role of the warm handoff from the primary care physician. They're using certain their behavioral health instruments to evaluate the patient's condition, providing support services for that beneficiary. That is, again, that critical piece of that general BHI. And again, we're going to see the same sort of required service components, but noting that now that we don't have the psychiatrist involved, we will also waive the systematic weekly case reviews. Next up on care management is the refinement to the remote monitoring codes. And as you recall, we have 2 types of remote monitoring. We have remote physiologic monitoring and remote therapeutic monitoring. In the world of RPM, that's remote physiological monitoring, the important development for 2026 is the addition of a new code for when the practitioner collects less than 16 days of data. So currently, billing these codes for monitoring patients, you had to cross the 16-day threshold every 30 days. So in a 30-day period, you've collected at least 16 days of data regarding the beneficiary. That was problematic because in many instances, the patients don't report the information or they don't stand on the weight scale so they can transmit the data to the practitioner. So last year, CPT created the new code that would provide reimbursement when monitoring and receiving only 2 to 15 days of data. And so CMS here in 2026 is adopting 99445. Interestingly, very interestingly here, CMS created their methodology for assigning the RVUs to these codes because it did not like, that's an understatement, it really, really, really did not like the idea of using survey data for purposes of determining what the practice expense should be for these codes. Remember, this is a practice expense only code. There is no professional component to it. So rather than relying on that survey data, it finally is breaking free of that and now is going to use data from OPPS. It's going to look at what has been the geometric mean cost under OPPS and then dividing that by the conversion factor, the non-qualifying conversion factor, it's determining the RVUs. And so for 2026, the RVU assigned to both codes, interestingly, is 1.42, which is actually, in the case of 99454, that's actually an increase because currently that is at 1.33 practice expense total RVUs. So again, note here, if you're only collecting 2 days of data, the practice expense is the same as if you were collecting 30 days of data, and both will be reimbursed at the same amount. Other change for remote physiological monitoring for 2026 is now providing reimbursement for treatment management services that involve less than 20 minutes of engagement with the beneficiary. Now is a new reimbursement under 99470 that provides reimbursement for the first 10 minutes of treatment management services. Still, remember, for RPM, you have to have at least some form of direct interaction with the beneficiary to bill for this code. That still holds true for 99470, but we've lessened the time down to 10 minutes. So again, it can be 5 minutes of direct interaction with the patient, and then 5 minutes of other work done on behalf of the patient. That's still going to work. That's going to be 10 minutes. If you go over 10 minutes, then appreciate between 10 minutes and 19 minutes, you're still going to bill 99470. It's only when you cross that 20 minutes that you're able then to bill 99457. And when you get from 20 minutes to 39 minutes, it's still just 99457. But when you get to 40 minutes, that allows you the add-on code then of 99458. So even though it's your time codes, you have to cross the actual time number to bill for the code. Keep that, and again, we've made no changes in any of the assigned RVUs for those code. In the world of remote therapeutic monitoring, same changes made here. So they've created that new data transmission code for RTM to allow for 2 to 15 days of data collected, and they will remain contractor priced as they are currently under the rules. They have also provided that for both respiratory, musculoskeletal, and cognitive behavior therapy. So those are the 3 types of RTM we can do today, and they've followed those same rules to go all the way back to 2 days of data, providing reimbursement. Similarly, in RTM, they've expanded out the treatment management services, again, to reimburse for that first 10 minutes, or effectively 10 to 19 minutes, that new reimbursement, and again, assigning half the RVUs to those codes. Next up in care management, we need to talk about FQHC and RHC billing changes that were made. So previously for the COCM codes, the CMS had directed RHCs and FQHCs to bill for those services under G0512, and so they only receive reimbursement for the services without an add-on. And now, effective the beginning of 2026, RHCs and FQHCs should use the usual CPT codes and will be reimbursed again on the national payment amount for those codes. Also, similarly, RHCs and FQHCs will no longer use G0071 for communication technology-based services. Instead, they'll use the individual codes that have been wrapped up in the G0071, and that's G2010, 2025. Codes, I can't do it as well as you, Valerie, at all. G2250, and then that new code 98016, also for sort of that brief interaction by telephone with beneficiaries. You're going to, again, bill under the codes, be reimbursed at the national payment rate for reimbursement there. Finally, let's talk, oops, I hit the wrong button. There you go. Let's talk about the SDOH reimbursement. Again, we go back now to 2023 when we first started reimbursing for these services under community health integration, principal illness navigation, and then SDOH screenings. And CMS has changed their lingo here. And there's a lengthy description in the final rule of using the term upstream drivers of health as opposed to social determinants of health. And those upstream drivers would include smoking, low physical activity, substance misuse, in addition to environmental drivers. So it's a language change to upstream drivers. As part of this, CMS had proposed to discontinue reimbursement under G0136 for SDOH screenings. They said, no, we think it's part of content of other E&M services. We don't think it's necessary to be reimbursing for these services, and so we're going to discontinue. This is, again, one of those examples where comments work because there were a number of comments that, wait a second, this has been a really useful tool for us to gauge beneficiaries in terms of their nutrition and in terms of their physical activity. And the administration is certainly putting a premium on addressing physical activity and nutrition. And so let us continue to use these codes to do these types of evaluations, because it is additional work beyond what we typically do in the E&M service. So CMS has.
Marty,
Sorry,
I was going to say, I think they did a really good job of commenting and saying and laying out the case why they saw it was above and beyond the E&M service. Because sometimes it's just, sometimes it just doesn't fall well on
Right.
CMS's ears. But this was really a well laid out case on why it is separate and how it would impact the patient. And so I thought, like you said, it's a good example of how the comments can work.
Yeah. And saving really an important code. But noting here that the evidence-based tools change, because the evidence-based tools we have been using for SDOH screenings, probably the most common was the Accountable Health Communities tool for reviewing the impact of environmental factors and social factors on the beneficiary. So now we're going to use evidence-based tools that are really focusing in on nutrition and physical activity. And you see there listed on the screen those that are identified by CMS in the final rule. That's not an exclusive list. They're very clear, not an exclusive list, but they're saying we recognize these as evidence-based. And so if you utilize these to determine nutrition as well as physical activity. Note again, the time remains the same. It's 5 to 15 minutes. It can be performed by staff, but again, direct supervision, not general supervision, direct supervision for these. But as Valerie noted, we can now have virtual direct supervision permanently. So that will certainly facilitate the delivery of these services. And remember, we can't do this more than once every 6 months for beneficiaries. So it can't just be a standing, every month we do it and get billed for it. We can only do it once. And again, reimbursement is relatively low, generally under $15, but it at least recognizes, as you said, Valerie, it's work beyond the E&M, and we need to recognize it as such. And I think as a provider community, we may be coming back to that to make the case in other areas that it's beyond the E&M code. So stay tuned there. Regarding community health integration and principal illness navigation, no real changes here, but more clarification. And I'm always excited to see clarification from CMS on any of the care management codes. But they note for CHI and PIN, these services can be personally performed and billed by clinical social workers, marriage and family therapists, and mental health counselors that are enrolled in the Medicare program. So again, this is creating another source of reimbursement for these behavioral health practitioners, that if they are doing CHI and PEN, and they are personally spending the 60 minutes to deliver these services, they can bill for those codes as well. Now, of course, note, there's going to be a reimbursement reduction because CMS generally reduces the reimbursement from the physician level down for these types of practitioners. But again, it is creating that opportunity. Now, again, in addition to those types of providers personally performing these services, then for a practitioner to bill for the services, they can be performed either by clinical staff, so an RN or a social worker, again, under the general supervision of the billing practitioner. Or why CHI and PIN have been such a big deal is that these have opened up reimbursement for community health workers, so non-clinical staff delivering services that are being reimbursed by Medicare through the supervising practitioner. Note again, though, that CMS has made clear that if you're going to be billing for community health workers, that they're going to need to meet any applicable state certification requirements. Here in Kansas, where I'm at, we have very well-defined criteria. of how you become a certified community health worker. To bill for that individual service then for Medicare, they'd have to meet those criteria. If it's a state that does not yet have certification criteria, and the ranks luckily are shrinking in that regard, but you would make sure that they have received appropriate training. Again, it's not a 30-minute lecture on how to be a CHW. The requirements for those states that have adopted certification, it is much more akin to an LPN type training. So make sure that those individuals are appropriately qualified to accomplish that. And then finally, because we've added the clinical social workers, marriage family therapists, and mental health counselors, they can't bill E&M codes. So we needed new codes for initiating visits. And so CMS has added 90791, as well as the range of codes for health behavior assessments and intervention services. Those can now be initiating visits for CHI and PEN, either when they're billed by these behavioral health providers, as well as billing practitioners as well. Just a note, and this is not in the final rule, but this is a new voluntary alternative payment model that was announced by the CMS Innovation Center on December 1, the Advancing Chronic Care with Effective Scalable Solutions, or the ACCESS model. It's a really, I think, exciting opportunity ahead in 2026 because CMS will be testing an outcome-aligned payment, or an OAP. I love that, OAP. This is a recurring payment that's made to a Part B provider for managing patients' qualifying conditions. You see there are 4 tracks, so 4 conditions on which they're focused in. This OAP payment is going to vary by the clinical outcome. So if you do a really good job of managing a patient, you're going to get paid more as that access provider. But also exciting here is if you are a clinician that is not necessarily providing these care management services, but you're aligning with an access participant, you're going to be available to bill for a co-management code. If you perform certain services, then, I think they're estimating it around $30 that you can bill for being involved in the patient's management. So primary care provider here, care management company that is participating in this program over here, they're billing for the OAP and receiving payment under the OAP. That allows then the primary care provider who's been managing this patient all along to receive that co-management fee. So a lot of detail yet to be ironed out. Oh, one other point to note is that it's like they've heard us talk about this long enough. If you're in this model, they are waiving the copay and deductible for the beneficiary. So finally, they've given us a vehicle to deliver these services without the copay or deductible. Again, we have lots of detail we need to see. We don't know what the OAP rates are, for example, so we will be seeing a request for application, a RAF, coming out of the CMS Innovation Center here shortly. And it's a short time frame because you're going to have until April 1st to apply to participate and for a July 1 start date. For those of you that can't pull the plug that quickly, there will be another round to begin in 2027 under this model. So more on access as we see detail in the RFA coming out of the Innovation Center. But again, it's really sort of that next exciting iteration of care management services. Yes, I get excited by this stuff. But anyway, let's wrap up with prevention and wellness, what CMS has done in this space for 2026. And most of this work has been done around the Medicare Diabetes Prevention Program. This has been a sweetheart of CMS, but they just have struggled to get it to a point that providers can actually stand up these programs. What has not changed is the eligibility criteria for being a participant in DPP. You have to be an individual who's at risk of developing type 2 diabetes. The particulars are there on your screen. We still have to have NDPP suppliers that have to separately enroll in Medicare. So even if you're a physician practice enrolled in Medicare, you're going to have to, in addition, enroll to be a DPP provider. And you can only accomplish that if you have met the CDC preliminary or full recognition for a DPP program. So it's the Center for Disease Control that has sort of been managing this DPP model in terms of the clinical aspects. And so you're going to have gone through the process of achieving recognition through CDC and their processes, which then will allow you to enroll in Medicare as a DPP. And then the core of this is having 1-hour group sessions with these beneficiaries who are at risk of developing diabetes. You have these 1-hour group sessions that are being delivered by trained lifestyle coaches who are using a CDC approved curriculum. There's 16-week core sessions and then 6 monthly follow-up sessions. So none of that changes. All of that is going to effectively remain the same. But what the big change is, to address this limited participation issue, is taking the lessons learned during COVID, and really improving how we deliver the services, and then also this simplified payment structure that CMS has created. So for 2026, okay, one more current state slide. The current reimbursement, that $26 if you deliver for each of those 1-hour sessions that you deliver. And remember, it's $26 per beneficiary. So if you have 10 people in the room or 10 people online, then you're going to be paid $260, assuming they're all Medicare beneficiaries who qualify. And we've allowed both in person as well as what they call distance learning. So it's real time. It's like we're doing distance learning right now, for example, because it's real time. But you could provide those services and receive that reimbursement. And then in addition, there's these incentives as beneficiaries achieve certain weight loss goals. You get those add-on payments. So finally, the big change to this program, they're going to extend that virtual option, which is that distance learning option, as they call it, through 2029. It was set to sunset. They're now going to extend it through 2029. And again, here's the big story. They've now added an asynchronous delivery modality through 2029. So rather than everyone having to get on at 8 p.m. and live through an hour-long session, now you'll be able to have your beneficiary access content at their own within their own schedule and access that content appropriately. To do that, to be one of these asynchronous delivery providers, you're going to have to separately enroll and obtain an organization code from CDC prior to delivering those sessions, and adhere to CDC criteria for doing so. And then also for each session, ensuring that the beneficiary is engaging with content, some sort of documentation of sessions, some knowledge checks, contribution to discussion boards, but make sure they're actually part of the process. And then being sure that you've provided some sort of live interaction on a regular weekly basis. Doesn't have to be audiovisual, doesn't have to be a telephone call, but you could have bidirectional text and email. Again, just ensuring that those lifestyle coaches are having some engagement with the beneficiaries. In addition to creating this asynchronous opportunity, CMS is also expanding the ways for recording weight measurements. In particular, if you have a weight recorded in a medical record, if it's been within the last 5 business days, that is sufficient documentation then for that MDPP provider to capture that bonus payment for achieving weight reduction in the delivery of services. And you can see here the difference, of course, with asynchronous is going to pay less. If you do online or in person, that's $26 a session. Asynchronous is only going to be $18 a section going forward. And you see here, again, this table taken directly out of the final rule. You see the reimbursement for these programs as they've now created the system. Finally, let's touch on digital mental health services. There's new reimbursement there was new reimbursement in 2025 for physician and practitioners that provide the device and engage with their patients who are doing DMHT for behavioral health conditions. You see there the current conditions of payment. It has to be furnished incident to a plan of care for behavioral health treatment. You must incur the cost yourself as the billing practitioner for the device, and the device you utilize has to be appropriately cleared through the FDA. The expansion for 2026 is that we are now going to include the devices that are being licensed by FDA, specifically focused on ADHD. So in addition to those behavioral health treatments, we'll now have DMHT reimbursement for ADHD. Whew. So in 2 short sessions, we have made our way through the Medicare physician fee schedule, and we have made it to the end of another year of webinars. We are looking forward to seeing you on January 14, when we will do a good old Washington update. Who knows what's going to happen between now and then? But certainly, as Valerie highlighted, we're waiting for legislation to see what happens with the extenders that are set to expire now on January 30, and we will wrap our heads around it. So with that, I'm going to shoot this back over to Jennifer to take us home.
Thank you all.
Thanks to our presenters, Marty and Valerie. Please remember to stay on the line once the webinar disconnects to complete a short survey. Later today, you'll receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available in the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete the short survey and post any additional questions you may have. On behalf of PYA, thank you for joining us. Have a great rest of your day.